Gastrointestinal upper digestive tract disorders. Disorders of the upper digestive tract can have a profound effect on the nutritional status, overall health, and quality of life for these patients. Anorexia is a lack of appetite. It may occur with many physical and emotional disturbances. It's not the same as anorexia nervosa. Causes can include nausea, a decreased sense of taste or smell, mouth disorders and medications, anxiety, depression, disturbing thoughts, decreased activity, and social isolation. We diagnose it through a malnutrition assessment, a weight over several weeks, labs such as hemoglobin, iron, calcium, vitamin B12, zinc, thyroid function tests, skin tests, occult blood tests, tests for cancers of the digestive system, lungs, and breasts. These patients may require nutritional supplements or an appetite stimulant. Nursing care. Make sure that their dentures are fitting appropriately and that is not a cause of their anorexia. And potentially provide small meals rather than large. Some patients may require assistance with feeding due to temporary impairments or long-term disabilities. These patients can include paralytics, arthritics, those that have neuromuscular disorders, confusion, weakness, or visual impairments. Diagnosis is directed at identifying the cause, and these patients may require some occupational therapy and physical therapy, potentially even some speech therapy. Assistive devices can be used to help allow the patient to eat independently. We might need to thicken liquids. Patients should always be set upright and leaned slightly forward. Allow the patient to direct the feeding if they are able. Touching the lips gently with a spoon will encourage the mouth to open. Make certain that you pace the eating episode and check the mouth periodically to be certain that food has been swallowed. And don't forget to offer fluids periodically. Stomatitis is the general term for inflammation of the oral mucosa. It might result from mechanical trauma of poorly fitting dentures, irritation of excessive tobacco or alcohol use, poor oral hygiene, inadequate nutrients, pathogenic organisms, radiation therapy or drug therapy, in addition to disorders of the kidneys, liver, or blood. Medical treatment will be aimed at determining the cause and eliminating it. If there is a specific pathogenic organism that has been identified, appropriate antibiotics, which are usually topical, or antiviral agents may be prescribed. These patients will usually require a soft, bland diet and encourage the use of a soft bristled toothbrush along with daily oral hygiene and good nutrition. Dental caries is tooth decay, also known as a cavity. Treatment will involve removal of the decayed part of the tooth followed by filling the area with a restorative material. Preventative measures can include good oral hygiene, fluoride treatment, and limitation of sugar. Periodontal disease will begin with gingivitis and then it progresses. Symptoms include inflammation, swelling, pain, and bleeding of the gums that, left untreated, can lead to abscesses around the tooth roots, causing loosening and possible extraction. Evidence has shown that there is a correlation between gingivitis and cardiovascular disease. Treatment includes dental evaluation, teeth cleaning, plaque removal, smoothing of root surfaces, surgical removal of diseased gum tissue, good oral hygiene, and regular dental care. Oral cancer is the most life-threatening disorder that affects the mouth. There's two types of malignant tumors in the mouth: squamous cell carcinomas that occur on the lips, buccal mucosa and gums, floor of the mouth, tonsils, and tongue, and the basal cell carcinomas that most often occur on the lips. Risk factors include prolonged exposure to irritants, including the sun, wind, and pipe smoking, tobacco and alcohol use, poor nutritional status, and chronic irritation. Symptoms will be tongue irritation, loose teeth, pain in the tongue or ear, ulcerations, thickened or rough areas or sore spots, hard white patches that are called leukoplakia, and this is thought of as a premalignant condition. Diagnosis and treatment includes biopsy, an endoscopic examination, and x-rays of the upper digestive tract and respiratory tract. Surgery, radiation, and chemotherapy might be used. Sometimes grafts are needed to close large defects that are caused by surgical procedures. Be sure that you assess for difficulty of swallowing or chewing, decreased appetite, weight loss, a change in the fit of dentures. Monitor the respiratory status, provide a soft or liquid diet, and alternative communication devices. If a graft has been used to cover a large defect, you need to monitor that graft color and warmth and immediately notify the RN or surgeon of any coolness or discoloration of the graft site itself. Parotitis is inflammation of the parotid glands. It causes painful swelling of the salivary glands below the ear next to the lower jaw, and this pain will increase during eating. It can develop in patients who are unable to take oral liquids for a long time, especially if their oral hygiene is poor, in weak patients and those patients that have little resistance to infection. We treat it with antibiotics, mouthwashes, and warm compresses, along with surgical drainage and potential removal. It can be prevented by providing chewing gum or citrus-flavored hard candy to help stimulate saliva production. Achalasia is characterized by progressively worsening dysphagia or difficulty swallowing. It's caused by failure of the lower esophageal muscles and the sphincter to relax during swallowing from possibly a neuromuscular defect. We treat it by avoiding constrictive clothing, determining the best position for eating, eliminating foods that are difficult to swallow, drug therapy, esophageal dilatation, or surgical cutting of the lower esophageal sphincter, which is also called the LES. Complication of dilatation is perforation of the esophagus. Cancer of the esophagus is not really common, and it does have a poor prognosis as metastasis has usually occurred by the time it's diagnosed. Most esophageal cancers are located in the middle or lower portion of the esophagus, with common sites of metastasis being the liver, lung, and aorta. There is no known cause, but contributing factors can be cigarette smoking, excessive alcohol intake, chronic trauma, poor oral hygiene, and eating of spicy foods. Complications will include esophageal obstruction and perforation. Symptoms include progressive dysphagia that begins with problems eating meat, then soft foods, and lastly liquids. Pain with swallowing that can be substernal, epigastric, or located in the back with radiation to the neck, jaw, ear, or shoulder. These patients might have choking, sore throat, and weight loss. Radiologic studies will include a barium swallow and CT scan to help diagnose the cancer. Treatment includes surgery, radiation, chemotherapy, and definitely good nutrition. Make sure you assess these patients for hoarseness, cough, anorexia, weight loss, and regurgitation. Provide them a high-calorie, high-protein diet. Encourage them to tilt their head slightly forward to swallow. Postoperatively, monitor for any leakage at the anastomosis sites and monitor their respiratory status. These patients might require some mechanical ventilation. Nausea is a feeling of discomfort that can be accompanied by abdominal pain, pallor, perspiration, and cold, clammy skin. Causes of nausea can include odors, irritating foods, infectious diseases, radiation, drugs, other chemicals, hormonal changes and imbalances, and digestive tract distension. It is very common following surgery. It's common with motion sickness and inner ear disorders, and lastly, pregnancy. It's frequently accompanied by vomiting, which is the forceful expulsion of stomach contents through the mouth. Very forceful ejection of the stomach contents is called projectile vomiting. Regurgitation is the gentle ejection of food or fluid without nausea or retching. Tachycardia and increased salivation will often occur just before vomiting. Complications will include dehydration with fluid and electrolyte imbalances, metabolic acidosis, and aspiration of stomach contents. So we treat it with antiemetics, potentially some IV fluids, limitation of oral intake to clear liquids unless the patient is completely NPO, a nasogastric tube, TPN if the nausea and vomiting is prolonged. Note any patterns with the nausea and vomiting. Inspect the vomitus for color, odor, and contents. Green is bile, bright red will be recent bleeding in the stomach or esophagus, and coffee grounds is old blood. Look for any undigested pills. Provide a damp cloth to the face and neck and encourage deep breaths. Assist the patient with hygiene and rinsing of the mouth. Assist with positioning if the patient is lying down to avoid aspiration, and have suction available if the patient is weak and unable to reposition themselves. A hiatal hernia is the protrusion of the lower esophagus and stomach upward through the diaphragm and into the chest. There's two types of hiatal hernias. The sliding hernia, in which the stomach slides in and out of the thoracic cavity depending on their position, and it's usually associated with GERD. And then the paraesophageal or rolling hernia, in which a portion of the stomach herniates through the diaphragm through a secondary opening. Complications would include ulcerations, bleeding, and aspiration of regurgitated stomach contents, and strangulation of the hernia itself. The exact cause is unknown, but it can be from a weakness of the diaphragm muscles. And contributing factors would include excessive abdominal pressure from obesity, pregnancy, abdominal tumors, ascites, and repetitive heavy lifting or strain, trauma, and long-term bed rest. It will develop in about half of all people who are older than 60 years of age. These patients may be asymptomatic, but they may have a feeling of fullness, dysphagia, eructation or belching, regurgitation, and heartburn, which is the feeling of burning and tightness rising from the lower sternum to the throat. We diagnose this with barium swallow examinations, CT scan, esophagoscopy, esophageal manometry. Drug therapy can include antacid, H2 receptor blockers such as ranitidine or Zantac, and proton pump inhibitors such as omeprazole or Prilosec to help reduce the gastric acid secretions. We need to change their diet and provide measures to avoid intra-abdominal pressure. Surgery would be the fundoplication. Nursing care, monitor for aspiration. Avoid foods that decrease lower esophageal sphincter pressure. And postoperatively, make sure these patients turn, cough, and deep breathe. Very important. Gastroesophageal reflux disease, or GERD, is the backward flow of gastric contents from the stomach into the esophagus. Non-erosive reflux disease, or NERD, is heartburn without tissue destruction. Contributing factors will include abnormalities of the lower esophageal sphincter, gastric or duodenal ulcers, gastric or esophageal surgery, prolonged vomiting, and prolonged gastric intubation. Complications include esophageal stricture and adenocarcinoma. The symptoms may have a sudden or gradual onset, may experience some painful burning sensation that's relieved with antacids, and if it's severe, this pain can radiate to the back, neck, or jaw. They might have acid regurgitation, intermittent dysphagia, and belching. Symptoms can follow activities that increase intra-abdominal pressure or ingestion of certain foods. We diagnose it through trials of medications to see if the medications are effective, radiographic studies, endoscopy, biopsy, gastric analysis, esophageal manometry, 24-hour monitoring of the esophageal pH, and acid perfusion tests. Treatment and nursing care will be similar to that for the patient with a hiatal hernia. We can also do drug therapy and a surgical fundoplication. Gastritis is the inflammation of the lining of the stomach caused from a breakdown of the mucosal barrier that normally protects the stomach from autodigestion. Causes: the Helicobacter pylori is the prime cause. Although NSAID use, stress, alcohol, red and black pepper, reflux of bile salts, prolonged vomiting, immune mechanisms, and CNS lesions can also cause gastritis. It's commonly classified as acute, chronic type A, and chronic type B. Symptoms will include nausea, vomiting, anorexia, a feeling of fullness, stomach pain, mild indigestion, and pernicious anemia. We diagnose it through gastroscopy, biopsy, lab studies that might include hemoglobin and gastrin levels, a hematocrit. We can do an occult blood and cytologic examination. We treat the symptoms and replace the fluids. Medications can be given to reduce gastric acidity. We need to eliminate the cause. We can also give corticosteroids, vitamin B12 injections, administer a bland diet. Any surgical interventions that are done are usually done to control any hemorrhage and help these patients avoid foods that aggravate their symptoms while you are monitoring for signs of bleeding. A peptic ulcer is the loss of tissue from the lining of the digestive tract. When the mucosa barrier protecting the lining from digestive fluid fails, then these fluids injure the tissue. Peptic ulcers can be acute or chronic, and they're classified as gastric or duodenal depending on the location. Gastric ulcers occur most often in men and older adults, while duodenal ulcers occur most often in younger men, with 80% of peptic ulcers occurring in the duodenum. The cause: contributing factors are stress, drugs such as aspirin and NSAIDs, infection, with most ulcers being caused by the H. pylori. Symptoms will include burning pain 1 to 2 hours following food intake, nausea, anorexia, and weight loss. Intractability is the term that's used to describe symptomatic peptic ulcer disease that does not respond to treatment. Other complications can be hemorrhage, perforation, peritonitis, pyloric obstruction, persistent vomiting, fluid and electrolyte imbalances. We diagnose this with barium swallow examination, gastroscopy, and esophagogastroduodenoscopy. Lab tests can also be done to identify the H. pylori. The goal of treatment is to relieve symptoms, promote healing, prevent or detect complications, and prevent occurrence. So drug therapy is intended to relieve symptoms, heal the ulcer, and cure the H. pylori infections and/or prevent recurrence. Diet therapy would involve permitting the patient almost any food that does not produce discomfort. Complications of the peptic ulcer can be treated medically or surgically. And if hemorrhage is suspected, a nasogastric tube can be inserted and attached to suction to remove and measure blood in the stomach. Gastric decompression, along with IV fluids and antibiotics, may be given. And detailed treatment of patients with peptic ulcers is included on your textbook page 814. Monitor for signs of bleeding, monitor their nutritional status, their digestion status, and cardiac status following any surgery. Cancer of the stomach was diagnosed in more than 28,000 people in the United States in 2017. The incidence is highest among men, people older than 70 years, and people of lower socioeconomic status. This carcinoma begins in the mucous membranes, then invades the gastric wall, and then spreads to regional lymphatics, liver, pancreas, and colon. The distant metastases will be found in the lungs and bones. There's no early symptoms in the early stages of this disease. Late signs will be vomiting, ascites, liver enlargement, and abdominal masses. Risk factors for stomach cancer include the H. pylori, pernicious anemia, chronic atrophic gastritis, a lack of hydrochloric acid, type A blood, a family history of stomach cancer, cigarette smoking, diets high in starch, salt, pickled foods, salted meats, and nitrates, and a history of the Billroth procedure. We diagnose stomach cancer through gastroscopy, biopsy, an endoscopic ultrasound, CT scan, bone scan, PET scan, MRI, laparoscopy, blood studies such as hemoglobin and hematocrit, albumin, liver function tests, the carcinoembryonic antigen, stool specimens can be examined also for occult blood. Treatment involves surgery, chemotherapy, and radiation. If the cancer is detected early, surgical options would include a subtotal gastrectomy with lymph node dissection or a total gastrectomy. Make sure with these patients that you're monitoring their dietary intake and their weight.